Good afternoon, everyone, and thank you for joining us. I'm Debbie Flotnick. I'm Vice President for State and Federal Advocacy at Mental Health America, and I have the great privilege of welcoming you today to our Regional Policy Council webinar, Leveraging Screening Data for Dollars. And our speakers today, our presenters today are Ben Harrington of Mental Health America of East Tennessee and Shauna Mulvihill of Mental Health Minnesota. And both Ben and Shauna are wonderful regional policy representatives. And this is one in a series, and we're so delighted that you could join us today. I would like to do a little bit of housekeeping, if I may. Are the slides advancing for us? There we are. First bit of business is that Mental Health America is very appreciative for the supporters that make the Regional Policy Council meetings, activities, including this webinar, possible. Neurocrine, Janssen, Myriad, Alkermes, Avivi, Otsuka, Takeda Lundbeck, Teva, and Sage Therapeutics. Next slide, please. So here's the important part for right now in terms of housekeeping. All of the participants will be in listen-only mode. This webinar is being recorded. You can listen to it later, and you can feel free to share it with your friends. A recording will be posted on Mental Health America's YouTube account. Can I have that slide? Thank you. Participants will receive an email when slides and the recording are posted. You'll be able to download them. And any questions that you have for our presenters, please type them into the chat box during the presentation. We will have question and answer with Shauna and Ben, and it'll be at the conclusion of their presentations. And Karen Howard, MHA Advocacy Manager, will be your host for helping the questions get translated to our presenters. We're ready to go. Tell you a little bit about MHA's screening. We want to tell you about our screening sites. We want to invite everyone to please check them out. In fact, we have now over 7 million screens that are completed in our latest data set. It's really been quite the amazing increase in the number of people coming to do screens. Since the pandemic, we've had over 2 million people take screens. The demographics hold true, with 2/3 of the screeners who come being under 24, 1/3 of them being 11 to 17. The folks, no matter what their age group, tend to be screening more positive or in the higher to more severe range for what it is that they are screening for than in pre-pandemic days. So you can see some of our numbers. As you can see, they are even higher than that right now. I'm ready to turn this over to our speakers, Ben and Shauna.
Well, thank you, Debbie. As Debbie said, I'm Ben Harrington, the CEO of the Mental Health Association of East Tennessee. It's my job to get us started. Our learning objectives for today are pretty strong. We are going to work with folks to help them understand and to be able to describe screening data and how to identify policy issues or community needs in your area. We're going to help folks identify effective outreach strategies to expand screening outreach, and we're going to identify ways to leverage this data, screening data, when seeking funding, which I know folks are all about. So I'm happy to get us started. You know, when we want to talk about screenings, we kind of have to figure out how did we get where we are today. And so I need to take us back a little bit in time. And when I started thinking about this presentation, I realized that we were going to go back to the rotary phone days. Rotary dial a telephone. That's a long time ago for folks. So this is a step back in time. Um, it all started with National Depression Screening Day back in 1991. And so, how we get to where we are today, it's an evolution. We started with three-part screening forms, if you can believe it. We ordered kits from a place called Screening for Mental Health. $150 got you a pack of screening forms, got you the instructions on how to score the forms so you could help a person identify what their treatment need level was. It also got you a VHS cassette and maybe a couple of posters for your screening site. Screenings in those days were live sites. We would recruit a place, whether it was a table at the mall, a community room at the local college or university, or even at a local hospital partner. So they were live sites. Wasn't the best for maintaining anonymity because people could see who was going in and out of the screening site. And certainly, next slide, a live site on a single day for National Depression Screening Day was not the most effective because, as we know, symptoms just clearly will not wait until the National Depression Screening Day or National Eating Disorder Screening Day or even National Anxiety Disorder Screening Day. So symptoms made it so that we couldn't just stay focused on a single day each year, and we had to create some plan in each of our communities to do this differently. We at the MHA of East Tennessee quickly decided we were going to make our screenings available year round. And so we weren't just going to wait till the next national day to arrive. Eventually, Screening for Mental Health would want to move their screening tools all online. And so that started things that direction after about 2000 or so. The national organization, Mental Health America, got into this arena um, soon thereafter. And, they got into it in a big way because screening for mental health resources weren't as robust as what Debbie has discussed with you today. Mental Health America has many more screening tools available to us and also the ability to help us um, tabulate the data. We work with Maddie. Shout out to Maddie at National. She's great. We can tabulate our data by region, so we can zero in, if you will, uh, on data for Southeast Tennessee. So if I've got a funder in Chattanooga that wants to know how this could work in Southeast Tennessee and how many folks we could impact, we could zero in on some of that data with Maddie's help. It's really important that we do so. So symptoms won't wait, and that's why online screenings are more important than ever before. So show me the money. I know that's why some folks are here today. They really want to talk about the money. How do you leverage it, Ben? How do we raise more funds for our organization? So let's talk a little bit about some success and some failures, okay? So success, we have been receiving United Way funds for this type of client service annually since 1993. So that's about $135,000 that we've received this way. In a few years ago, our United Way asked partner agencies to try to go big and propose a game-changing funding. And so we did. We actually proposed securing screening kiosks. So think like an ATM that's mobile. We could put wheels on it. It could go to um, health fairs, benefit fairs with employers, that sort of thing. Would have been kind of cool. Our funder that we were proposing this to actually loved the idea, but couldn't wrap their heads around being the major sponsor here or the major funder. And so the walkaway was they declined the proposal because they didn't want to assume all the risk for buying these screening kiosks. So that was kind of a letdown, if you will. Next slide, please. Next slide. So one of the things we did learn is, we have to start realistically thinking about, well, how do we target our fundraising to reach specific audiences? And this could be very helpful. This is not the MHA of East Tennessee. This is actually the MHA of the Mid-South, where Tom Starling is the CEO. And so they very successfully worked with a funder that was interested in supporting veterans and their families, but also supporting military families. And so what they did was they heard and listened to that funder. And so they targeted their proposal to reaching that audience with suicide prevention outreach, with crisis text line, as well as the ability to offer depression screenings and other screenings to a veteran community. And so the really neat thing is, by wrapping a bus, they got a lot more real estate in which they can put their message on the bus or on the billboard that's so mobile in this community. Clarksville, Tennessee actually is the fifth largest city in the state of Tennessee, but it was the third highest zip code in Tom Starling's catchment area for the MHA of the Mid-South. And so they knew they needed to target that area. Clarksville is also where Fort Campbell is, and hence, so it's a great way to reach that funder's needs. Now, if you notice over by the driver's window, there's a QR code, and the QR code allows people to take a snapshot of the code and go straight to their screening site. So that's pretty important. Next slide, please. So I've got a kind of a funny picture here of a tail wagging the dog, and that's really what targeting our audience is all about. Funders often will identify their area of interest, whether it's funding women, like what we have here on the left side of this screen with the Mount Rest Fund in Knoxville. They target and support programs and services that support women. So they gave us money for connecting screenings to our call center to support women in Knox County, because we listened to them, much like Tom listened to the funder on veterans. We don't have to be solely focused on veterans or women's funders. There might be funders out there that are interested in men's mental health or youth mental health. Particularly important nowadays, we keep hearing the need for addressing healthcare disparities. Well, we could focus our outreach towards persons of color. And in fact, there's actually robust research about the effectiveness of mental health screenings with people who speak Spanish. So it's really, an opportunity for us to figure out what are the funders, what are their areas of expertise, and how do we tailor this to them to interest their support. Go ahead, Karen. Next slide, please. The thing I would suggest also, beyond targeting a subpopulation, is let's think about targeting special situations. Now, I naturally have to tell you our current status here in Tennessee. Um, the MHA of East Tennessee has secured $65,000 in targeted uh, screening support because of COVID-19. So $65,000. We've got that through two smaller grants. One was through United Way from their disaster fund, and one was from a community foundation for their disaster fund. And so this is the tail wagging the dog. The funders set up emergency funds to try to support our community because of the pandemic. And so what we did was we paid close attention to the surge of screens that we were experiencing, but also the surge of calls in our call center looking for assistance finding a provider. And so those two things factor in well together to present a need for our community. And that's why we're able to leverage those funds. So then along comes the Tennessee CARES Act opportunity this summer. Our state received CARES Act money from the federal government, and they held some of it for different business types of businesses. And so for nonprofits, they asked us to look at, did we have any expenses that dated back to March that weren't um, reimbursed with any other source? So did we have United Way pay for PPE, or did state grant money pay for PPE? Well, those things would not be able to be counted towards CARES Act funding. So we had to look at something different. And we looked at what we'd already done with our United Way Disaster Fund money and East Tennessee Disaster Fund money, and realized, okay, that is painting the picture. That's paving the road for us. We could, with CARES Act money, actually expand how we reach people in a big way, um, and help promote uh, mental health screenings. The key was that this outreach had to be connected to COVID-19. And so we had to look at that kind of hard and look at what was truly going on. And in our state, we know that there is a COVID-19 mental health consequence, and it is driving things in a big direction, as Debbie indicated, with 2 million screens at the national level since May. So I'll talk more about this here in a sec. Go ahead, next slide, Karen. So this slide, I want to just point out one thing. This is not Ben's material or Ben's slide. It's actually from the Pew Research Center. So it's a very highly respected, regarded think tank research entity. And so they conducted this survey for 1 week in the month of March, March 19th to 24th. And realistically, what we're talking about is the Pew Research Center is saying, 43% of Americans felt anxious, nervous, or on edge that week. And 32% had trouble sleeping, 24% were depressed, and 19% were feeling lonely. Those numbers really don't contradict what national screening data is at all, nor will they contradict your own data, but it's a separate study that you can cite for your potential funders. The thing I want you to walk away from about this slide is it's a 1 week snapshot. And the scariest thing for us in the behavioral health business is, if this is a 1 week snapshot, what if these same symptoms persist for a 2 week period? Well, as clinicians, if they persist for a 2 week or more period, we're going to start diagnosing people. What if they persist and go unrecognized and untreated for 2 months, 3 months, 6 months, a year? Well, now we're talking about a situation becoming quite chronic and increasing the severity of that person's treatment need. And so we want to do what we can to intervene early. And this slide is what led us to do those earlier applications and leverage those dollars. So the next thing I want to share with you, go ahead, Karen, is other evidence to cite. If we are going to follow some of our funders' lead here in terms of, responding to the COVID pandemic, it's important to note some important pieces of data here. The first one, as I go across the screen left to right, is from the JAMA network, the Journal of American Medical Association Network, and CDC, reporting that 41% of Americans are experiencing at least one adverse behavioral health condition because of the pandemic. Now, that 41% is double the national average when you think of, well, what is the prevalence of mental health conditions in our country? So the pandemic is causing a doubling of persons with mental health treatment needs. And of course, CDC's major concern is, if that becomes well entrenched or established, we really have the risk of things becoming chronic. Lancet is a publication from Britain, and it reports a significant onset of psychiatric conditions after COVID, So 14 to 90 days, 21% of um, COVID patients can expect the onset of a psychiatric condition. Now, think about that number and then start to translate it to your own numbers, okay? So here's a translation. 21%. Tennessee hit 405,000 COVID patients yesterday. 21% equals 85,000 persons who now will have a mental health condition or behavioral health condition on top of those that we were already struggling to serve. So that becomes an issue. Now, Debbie would also want me, I'm sure, to put this in a different context. What about nationally? Well, nationally, we're at 15 million people with COVID. 21% means we have more than 3 million new people with a mental health condition that will be needing to find services. So this becomes problematic. The Asian Journal of Psychiatry did some terrific research too, and what they've been able to identify is people that we already knew, our clients we already had, or our mental health centers that already had, that sort of thing. If they develop COVID, their symptoms are going to worsen. So that's going to further strain your system too. And then the Psychiatric Times reported much higher percentages of people with PTSD, depression, and anxiety. And so those are well over the usual prevalence data. So again, this is going to start pressuring our system. Next slide, Karen. So I'm not going to get too deep in the weeds on this particular slide, but this is trying to show you a bar chart of our experience here in East Tennessee. Now, I will tell you our 3-month average of screens, December, January, February, is about 215 people screened. But come late March and into April, we started to use some dollars to boost social media posts to promote screenings. And so that started to drive our percentage up a little bit to 71%. We also did some news stories with various TV stations that didn't hurt us in promoting screenings. But then you get into May and June. We didn't spend any money. All we did was we promoted May as Mental Health Month. All we did was promote Men's Mental Health Month, and in July we promoted BIPOC. And so we didn't spend any money then. And by the time you get to August and September, we're talking about a 332% increase in August and a 468% increase in September in our screening utilization. And that's all COVID related. So as that number started to go up and COVID started to drive that number, that's what we were able to use to leverage the state money, or the state pass-through money of the federal money for the Tennessee CARES Act. And so that plays a big role. Now in October, we spike up, and that's all related to the public health marketing campaign of mental health consequences to COVID. So go ahead, next slide, Karen. I'm not going to get in too deep on the mental health campaign, but it has a number of things that are part of it. We're spending $55,000 of federal money to help people better understand and become more aware of mental health issues, and particularly to market our mental health screenings. This is going to take the place of news stories every Monday during Mental Health Mondays. It's also going to take place in commercials, which we produced with the TV station, and they are running, every day during the news hours. So now the morning news hour, the noon news hour, the early evening news hour, the 6 o'clock news hour, and then the 11 o'clock news hour. So those ads are running a lot. And then what our dollars we're able to also buy is something called OTT. OTT is called over the top, and that is when a television station can take a commercial it produced, and it can also distribute it to the cable networks. And so the same commercials that run on the news station also run on Discovery Channel, sports channels, DIY, HGTV, etc. So we're getting a tremendously broad reach. And so we started the campaign. We intended only to spend about $38,000, but then because of some accounting issues, we sunk the remainder of it in. And so we're spending $55,000. It's going to get us 50 million impressions in a region that has about 2 million residents. So it's going to get significant exposure. And both what Tom did in Clarksville and what we're doing, it's all about playing that multiple exposure game when it comes to marketing. And the more people are exposed to something, the more they'll pay attention to it, and then they might respond. So that's important. And so last slide for me, Karen, is let's talk a little bit about policy considerations and funding considerations. So naturally, when we have at the national level the 15 million people being impacted by COVID and 21% going to have the onset of a mental health issue because they had COVID, that becomes 3 million people. So that is a huge consideration. And, the problems that we know so well because of the before stage 4 philosophy, if we don't act now, then those issues could become chronic situations, and that becomes quite problematic. The other thing already concerning is folks with pre-existing conditions. Their needs certainly ramp up in a big way, and is the current system that you have sufficient to support these individuals with their more dire treatment needs, or is the system going to be overburdened by adding new people? So those are significant concerns. I will also say the degree of suicidality that we are experiencing might be problematic too. Is the crisis system able to respond there? So left unrecognized, all of this becomes huge before stage 4 issues for us, and we care so much about that. But lastly, it's the pipeline. It's the capacity. Um, we're adding a lot of more people to the treatment need area here. In Tennessee, that's adding 85,000 people. And are we going to be able to serve them, or are they going to get stuck in a waiting line somewhere? Are they going to have to wait 30 days, 60 days, 90 days to be seen? And if they have to get into a wait list situation like that, that becomes a parity issue in my eyes, and I'm sure many other people's eyes, because I don't have to wait to see the primary care doctor. I can call and get in easily enough this week. But I shouldn't have to wait 90 days because the insurance company doesn't have a strong enough network to have more providers when they are there. So those are some things we care about, and certainly connect. The funding implications, are connected directly to the policy. Do we have enough resources to proactively screen the population that we're supposed to screen? Do we have the ability to screen early so we can start treatment early? Do we have the resources to support in various systems, whether it's Medicaid or other systems, to be able to support folks? So I'm going to turn things over to Ms. Shanna, and then we'll be around for question and answer at the end. Thank you.
Great, thank you, Ben. And I'm going to talk a bit about how Mental Health Minnesota has been using screenings, how we're promoting them, and how we're using the data to really dig more deeply into policy issues, as well as talk to funders about the needs. So I think the first step for us has really been about tying all of our programs in with screenings. And so we've wrapped the mental health screenings that we have on our website into the organizational services that we really promote. And I'll show you how we do that in just a minute. So because we've done that, it's helped us to promote all of our services as really a part of the before stage 4 approach to mental health treatment and services. And we're also able then to show kind of a continuum of services that range everywhere from identifying symptoms to help seeking to getting support. And it also allows us to tie these services and the program data more closely together so we can seek funding and support for those programs. So this is just an example of kind of how we've tied those things together and branded them all together. These are 4 different brochures that we have, and on the opposite side then is more detailed information. But the Get Informed is more just a general education piece. Get Screened. We also use a QR code that takes us directly to our unique custom link to the MHA National Screening. Get Help is about our mental health helpline that provides information and referrals. And then Get Support is about our warm line, which is peer support for people living with a mental health condition. Then I just want to talk briefly about some themes or promotions and things that we've done in the past. Ben did this as well, and kind of some target audiences that we've done in the past. One of those is college campus welcome days or back to school has been a big time for us to be really promoting screening pretty heavily. Given what we know about when a lot of symptoms start to show up for folks, as well as things like, the number of, and Debbie mentioned this earlier, the number of people who are screening who are under age 24 or even under age 17. So that's been a big push for us, usually every fall. Had to find some creative ways to do that this year because we can't be tabling out on campuses and things, but we have been working on that still. Mental Health Day at the Minnesota State Fair, just another example of how we kind of wrap this into everything that we do. We have a trivia wheel, that we have trivia questions that people can answer. And then as a part of that, we tie all those questions back to our services. And so we may have a question about prevalence of anxiety disorders, for example. And so then when we, the person will guess, it's a multiple choice. And then when we give them the correct answer, then we'll also say, and by the way, did you know that we have this screening tool? So we're always really tying that stuff together. At Mental Health Day at the Mall of America, we had a screening kiosk available. And so essentially that was just set up with tablets. We worked with the Microsoft store there, and they provided tablets for us to use where we had our custom site there. And obviously at a place like the Mall of America, certainly our target audience essentially was youth and families. And so we really kind of highlighted the importance of screening early and what those, it kind of talks about the parent screens and youth screens and some of that. We also are beginning some work with primary care physicians to promote screenings. So, most of us have completed these, the paper screenings at a primary care visit in the past on the PHQ-9 or the GAD. And so we want our primary care physicians to be paying a lot more attention and handing out these kind of resources to people, in part because in Minnesota, like in many places, primary care ends up kind of being the default for being a gateway into mental health services. And so we want them to have some resources and what they need to be able to pass someone on. Then finally, we've also been kind of thinking about a new focus on promoting screenings for people with physical health conditions who might be more at risk for depression or anxiety in particular. including COVID-19, but I've, in meetings with hospital systems recently, they've also been talking a lot about, you know, a variety of different conditions where they're seeing, you know, more and more recommendations that people are watching what's happening with their mental health as well. So it seems like that would be a great place for us to really promote the screening tool. So using the data to show the need. As I said, we've really worked to tie all of our programs together. But, you know, mental health screenings obviously have increased significantly across the country. In Minnesota, our screenings increased by more than 600% between March and October of this year. And I'll show a graph to show that in the next slide. But during that time, also our helpline calls have doubled, and our warm line calls went up by 30% just last month. And so, you know, those are tools that that are available on the supports piece, on screening to supports. And so I think we can attribute at least some of that increased volume to the fact that more and more people are screening. The other thing that we're really working to do is examine our screening data to really start to identify specific populations where we can both evaluate how to improve or expand programs to meet those needs, as well as share some of that data with other service providers. And so that may be geographic area, that may be age. You know, we're literally paying attention to what's happening with that. Oh, that's okay, Karen, go ahead. So this this slide just shows the significant increase that we've seen in our screenings. The blue bar is 2019, the orange bar is 2020, and you can see in October, in 2019, we had a little over 400 screenings, and in 2020, we had almost 3,200. In Minnesota, and I just got the November numbers this morning from Maddie, and it looks like we were over 3,000 again in November. And so we are just seeing a really consistent, huge increase in the number of screenings coming through. So this slide is talking a bit about how we're bringing that screening data into policy and service discussions. So I just want to give some examples of that, because I think these are things that we can all do with our data. First, we've been able to bring up screening numbers in a lot of recent conversations with legislators and DHS, with the governor's office, as we start to discuss the mental health needs that we anticipate coming, and the importance of maintaining funding for those treatment and services at a time when the state will be facing a budget shortfall in the next biennium. We've also shared our data with counties, with health insurance companies and hospital systems. And we've done that for a couple of reasons, but in this slide, you know, what we've done is kind of compare the screening data that we're seeing to the service utilization numbers that they might be seeing, and thinking about where's the disconnect, essentially, because what I'm hearing from a lot of our health insurance companies is that they're not really seeing the increase that we would think would be reflected by the screening numbers. And so we've just been sort of talking about, like, what does that wait time look like? How can they do better or different outreach to their members to be able to address that and make sure that they're getting the help that they need. And then the last bullet is just an example. One of our counties is actually planning to integrate our screening data into this behavioral health dashboard that they've created recently, and showing quarterly data and year-over-year comparisons for their county. So this is the last couple slides are talking about using that data to fundraise. So on the left, you'll see a piece that I sent out by email. This was from Minnesota's Give to the Max Day, which is kind of like Giving Tuesday, except it's just a big push in Minnesota every November on a certain day. And there's a lot of companies that match donations on that day and things like that. So this is an example of a way where I used our screening data to really show the need, and again, really tied it more closely to our programs. And so you can see, I noted, 3,200 people completed our online mental health screenings in October, a 600% increase since last March. But then really, you can see in that next sentence, me saying our mental health screenings have skyrocketed during the pandemic and demand for our services and supports have never been higher. So that's one sentence that ties together everything that we're doing. So really thinking about using that data to fundraise, the sheer number and the increase in screenings in recent months, it's so significant that it does catch some immediate attention of donors and even potential donors when they hear that. More people completed screenings in Minnesota between August and October than in the entire year of 2019. So that's another statistic that I share a lot. So looking at, creative ways you can compare data to get kind of hit on the right ones where people are really going to pay attention. In our state, no one else provides online screening tools. And so by providing those, it really shows a proactive approach, I think, to mental health, but it also shows that we're doing something that's unduplicated and needed in our state. Our message to donors really demonstrates the need. So when we see those screening numbers, it shows that there are a lot of needs out there, and then shows what we're doing to meet those needs by talking about our helpline and warm line and our website and all of that. So as I noted, this messaging was part of our Give to the Max Day in November, but was also a primary part of some social media fundraising efforts we've done recently, as well as our end of year appeal. So finally, I wanted to just talk a bit about using our screening data in grant seeking, because I think it's been useful in conversations with individual donors and with outreach around that, but it's also been really at the forefront of a lot of conversations I have with supporters that are more foundations or corporations or health insurance companies. So I just wanted to talk a little bit about that. Because, a lot of funders right now are particularly interested in funding work that's related to COVID. And for a while last spring, it got pretty disheartening to try to seek funds from foundations and others because they were very focused on physical illness and really focused on what maybe we'll call basic needs related to COVID and other things. So, can you go back, Karen? Okay, thank you. So using our screening data and can really demonstrate that need and how it's really related to COVID at this time, and really show the relevance of your work right now and how important it really is. So truly, in almost every single conversation I have with an existing or potential funder, I bring up that significant increase in screening numbers. And I talk about it at different meetings with a lot of different folks, just so they're really paying attention to what we're doing. And because we've worked to tie those programs and services together and tie them very closely with screenings in terms of the other things that we do, it makes it for a really easy transition to asking for financial support for those next steps after screening. So like our helpline for information and resources, or our warm line for support. And in just the last few months, I have been able to successfully get almost $250,000 in support from insurance companies, from counties, and the state in support of our work by using these strategies. And also by using a real demonstrated return on investment that shows reduced use of intensive services because our programs haven't been available during this particular time. So now I'm focused a bit more on seeking funds for doing some of, similar to what Ben is doing, to really promote and market screenings in some new ways. And with that, I think we're going to be ready for questions.
Thank you, Shauna. Thank you, Ben. You are amazing as always. And we've seen some questions come in. Karen's going to moderate them, but I'm going to kick them off with a couple of things. Some of the things that have come into the chat, I wanted to address straight away about how the screening works. When you have an individual URL, which Shauna has and Ben has, it links directly to the national MHA screening site. But because there's that individualized URL, that data comes back to the affiliate or the associate member of MHA so that they can see who's coming through their website. Now, once someone takes a screen, if that screening is showing a degree of positivity, it goes directly to what we refer to as S2S, that's screening to supports. What we have found since the very beginning of putting up the screening site is that people have told us that they want some do-it-yourself tools. And part of this screening is because so many of the people who take a screen, and even those who screen positive, 60% of them have never had a diagnosis, nothing at all previously. So they're moving through the steps of change where they're ready to reach out for more immediate help, but a lot of people just want to start with some information, and that's what the Screening to Supports website provides them with. So I just wanted to let everybody know in case they weren't familiar. I would also recommend to all of our participants today, if they haven't done so, to go to the MHA screening site. You go there right from MHA National, mhanational.org, and take a screen yourself. Play around a little bit with it and see what some of the materials that come up in S2S, Screening to Supports, are. That'll give you some background. And before I turn it over to Karen, our policy team wanted to start with some questions for Ben and Shauna about the impact that you're seeing in your areas about when people take a screening. You obviously, I mean, we've seen that in recent months, you're seeing far more people driven to your MHAs for services that you provide. But what happens when funders often ask us this, and over the years they always have, if you're getting a lot more people screening and they're seeing that they're having issues and we don't have the capacity, well, that's a problem. How do you address those kinds of things with the funders?
Well, Debbie, I think the thing funders need to know is, do screenings work? And the clear-cut answer is yes, screenings do work. People get an answer to what's been troubling them, and they find out it's real, it has a name, and that the condition is a condition that's easily treated. So immediately the screener gets that information, and then they can use that. But funders really want to know, are screeners motivated to take the next step? And the answer is, again, pretty clear. The answer is yes. I'm going to date myself. Early National Screening Day data showed 56% of the more severely impacted screeners reported that they would seek help and did so within about 45 days. Now, NIMH then followed up on that data from 1995 and asked a number of MHAs to do a similar study, but with the populations that we screened back in those days. And so we did participate in that study, and what we found was 59% of people who screened severely ill did enter treatment within 45 days. Now, add to that body of evidence is screening for mental health went and then did a follow-up study after it had migrated things online, and it found 65% of screeners were motivated by their results to seek and enter help, again in the same time frame. So for anyone who's really trying to prove that case to the funder, it's quite a robust body of evidence to prove that it works and people are motivated to seek and enter help.
And Debbie, I think I would add, for us, that really opens up another conversation about our services, because the things that we do, people can remain pretty anonymous. Our warm line is anonymous, our helpline as well. We ask very little information, and we, if we have, if someone wants an email follow-up or something, we will get that, but we don't keep any real records that have any kind of personal or identifying information. And for a lot of people, that feels really good at a time when maybe they're not sure if they're ready to call their insurance company, and they're not ready to, or their EAP, or even share, their screening information with friends or family, or talk to a doctor or anyone. They just want to start to get some information, or just want a little bit of support. And so that's something that we can offer to people in sort of those early stages, perhaps before they're even at the place where they're ready to seek some additional help.
Thank you, Shanna. Thank you, Ben. You bring up really important points about the screening data. I also just want to mention for our participants that when people do come to the screening site, whether it's via an affiliate like Shanna or Ben's, or they come through MHA National, it is anonymous. It is free. It is anonymous. Why do we know where folks are? Because we ask them optional, and the important word here is optional, demographic questions such as, what's your zip code? So we can know where they're coming from. But we also know if they came through the URL that leads back to our affiliate or associate members. We also know about their age and their ethnicity, and we ask them some questions, but again, those are optional. But we find that almost all folks who do come are happy to share that information that doesn't identify them, but helps us have a better understanding of who it is that's coming. Karen has some questions to share with our speakers today.
Hi, everyone. I'm Karen Howard, the advocacy manager here at MHA National's office. And it seems like there are some really, really good questions that have come in. I'm so glad that Ben and Shanna and Debbie have clarified the screening tools are all hosted on MHA National's website, but that affiliates and associate members have their own custom link and can receive monthly reports from our program manager, Maddie Reinert. For those asking about how they can get their individual links to promote and start collecting affiliate-specific or state-specific data, like from Karen to Carrie at MHA California, we wanted to share that Maddie Reinert is the correct person. So if you reach out to your regional policy council member, Ben, Shanna, Barb Johnston, or Mo Keller, they can get you in touch with the correct person at MHA National's office to facilitate that custom link description that you can host on your website, and then receive regular updates on what the data looks like for your state or for your affiliate link. Another question that came in that's really good and I wanted to highlight is, have there been increases in rates of suicidality over the last 9 months? And if so, what is MHA's role in that? Ben or Shanna, do you have an answer for that question from Luke?
Well, I think that national data has already reported that there's a higher percentage of screeners reporting suicide contemplation than in a similar time frame from last year or the year before that even. And so um, that is indicative that folks are really hurting, and that their situation currently with the pandemic, with loss of loved ones, loss of jobs, has made things quite dire for them. And so that's the data from national that is really important. And um, you know, we can't speak about it enough. We've got huge problems with people who need to get help, and if they can't get help, then the connectivity to suicidality or completed suicides is certainly real.
Ben, I want to jump in here with the fact that MHA has been asking as one of its optional questions at the end of screening is, are you thinking about hurting yourself or ending your life?
Right.
And if so, how many days per month? So we have the data on that as well. In terms of translating into numbers of actual suicides, that data is slow to come in and it lags. So so I'm talking about the national sets of data. But what we have that nobody else has is we can say how many people answered those questions about how they're feeling with respect to hurting themselves or ending their lives. So that's another really remarkable, unique thing about the MHA data.
Go ahead, Shanna.
Yeah, I would just jump in and say, I think, in response to that, to those increased numbers, we've also seen our services, really the level of intensity of a lot of the calls we've taken has really gone up a lot. I'm sure, everyone's really experiencing that if you run any kind of services out of your MHA. So something that we've really done is it's added some additional training for our staff. That adds some more training on suicide risk assessment, as well as substance use disorder, because we're seeing a significant increase in that as well as cultural competency. And so really trying to build up those areas of the training we provide to our staff and volunteers. And that's something, in terms of tying that back to fundraising, funders, particularly the foundations and the health insurance companies and others, have really grabbed onto the fact that we are paying attention to what's happening in the world and adjusting accordingly. And so, the fact that we are looking at our data and looking at, what's happening around us and saying, okay, we need to be able to improve our programs. We need to be able to improve our staff's ability to serve people. So these are the things we're doing to do that.
Thank you so much, Shanna. I have two other questions that I really wanted to get to. They're awesome before the end. One from Bree, who asked that because we're a fairly new MHA and to grant writing and building programs, would you speak exactly to what you seek funds for when writing these grants for the screening tools? Is it, she's a little uncertain whether the grants are asking for money for hosting the screening tools on the website, which doesn't really have a cost. And so wanted to know, what are you asking for?
So in my case, and then I'll let Ben answer on his, but in my case, where I've been successful is in using the screening data to show the need and translate that into the fact that our services are needed and asking for funding to support those. Our warm line in particular, because that's my most costly service.
Yeah, Karen, I would concur with Shanna, but we also ask for the funding so that we can promote the screening availability. What probably the cheapest advertising around is posting to social media And you can boost those posts to broaden your reach beyond, your traditional followers. We have more than 4,000 followers, just our Facebook page alone, and of course we have other pages like Instagram and a youth-based Instagram and stuff like that. But when we are boosting a post, we want it to go a lot broader to help people that we've never known about, and help them understand what signs and symptoms of certain conditions are, or signs and symptoms of suicidality is, that sort of thing, so that that can help motivate them to take a screen. And so if we boost a post, we might be spending $200 on a post that's going to get, you know, pretty wide spread availability. And the same would be true if we're going to buy, advertising on TV. That's what the $55,000 was for, was to buy advertising to help get us, exposure to, so many people over and over and over again.
Thank you so much. We've hit the 3 o'clock mark. So what we'll do is wrap this up. We'll make sure the slides and recording is posted to MHA's YouTube channel and website by next Monday or Tuesday. And we will follow up with Q&A. Ben and Shanna have put their direct emails right here in the conclusion slides. So please do follow up with them directly if you have an urgent question. And I'll let Debbie just conclude with her remarks.
Well, I just want to say thank you again. And we have one more Regional Policy Council webinar for the year to close out the year. And that's next Tuesday, December the 15th at 3 o'clock Eastern Time. And Mo Keller and Barb Johnston will be talking about telehealth and opening doors to new mental health care and to more mental health care. So I hope you'll join us next Tuesday. We again really appreciate Ben and Shanna sharing their wisdom and their experience. If you have questions for Ben or Shanna directly, please feel free to contact them. If you want to reach us at National, we're all available to you at any time and happy to answer the questions. So thank you, and I hope to see you all next week.